Hey everyone, this is my first video that I'm posting on YouTube. It's cardiac pathology. I'm just going to go over some high level concepts, not getting into the nitty gritty details, but just going to go over some concepts that might have been tricky for some people. This video is very helpful for step 2 CK and clinical clerkship shells in American medical schools. So you can follow along. Let me know if this has been helpful for you. So let's talk about heart failure for a second. This is just an easy set of concepts. First of all, how do we know if something is left or right heart failure? Let's think about what happens if that part of the heart were to stop working. If there was increased pressure in the left or right heart, there would be backup fluid into the circulation that supplied it, right? So then you would end up in fluid buildup of wherever that stemmed from. So for the left heart, that presents as pulmonary findings due to transudative fluid being pushed out of the capillaries and into the lung interstitium. This would lead to dyspnea or difficulty breathing and findings on chest x-ray like curly B lines. And for the right heart, the fluid buildup would take place in systemic veins like the jugular vein, leading to jugular venous distension, and veins in the extremities and liver, leading to peripheral edema and hepatosplenomegaly. And just random high yield is normal JVP is 3 centimeters above sternal angle, so if it's anything above that, it's indicative of JVD. So congestive heart failure simply means left plus right heart failure. Also, the most common cause of right heart failure is left heart failure that progresses to right heart failure. So in congestive heart failure, there would be both pulmonary and systemic findings, and PCWP, which is pulmonary capillary wedge pressure, would be elevated as well. And cor pulmonale is right heart failure due to pulmonary cause. The left heart is completely normal, so there's no backflow into pulmonary capillaries, and PCWP is normal. The classic presentation is patient who has JVD and peripheral edema with obvious lung disease or demographic for pulmonary hypertension. The typical demographic for that is young female in reproductive age. And other atypical presentations are bronchopulmonary dysplasia in neonates and obstructive sleep apnea. The demographic for obstructive sleep apnea is overweight man in middle age, waking up in the middle of the night and sleepy throughout the day. So let's talk about cardiomyopathy. So sometimes these terms are thrown around and people get confused about what they really mean. So I'm just going to talk about the 3 main types of cardiomyopathy: dilated, hypertrophic, and restrictive. When you think of cardiomyopathy, think of something wrong with the heart tissue that's stopping it from working effectively. So for dilated cardiomyopathy, there is volume overload, usually due to renin-angiotensin aldosterone activation, called RAS, and fluid retention that is causing the heart to expand eccentrically or outwards to accommodate the increased volume. So to make it simple, muscle fibers are added in series, which means the fibers are being added to the end of the chain. Therefore, the muscles are getting bigger but not thicker. The heart loses the contractile function, leading to ejection fraction being reduced, increased compliance leading to increased end diastolic volume, otherwise known as preload. And due to the Frank-Starling law that states that pressure and end diastolic length are proportional, increased end diastolic pressure. There is decreased systolic pressure, which is forced during contraction. There is a S3 heart sound. When you think of S3, just think volume overload. And the PMI is lateralized, which means left ventricle hypertrophy. So the causes of dilated cardiomyopathy are alcohol, wet Burberry, Coxsackie B virus, cocaine, Chagas disease, drugs, also pregnancy, hemochromatosis, and rheumatic heart disease. A common acronym is ABCD. So for treatment, you want to lower sodium to prevent fluid retention, ACE inhibitors and angiotensin receptor blockers to lower blood pressure and prevent cardiac remodeling. Beta blockers are also helpful to lower cardiac workload, and diuretics to flush out the excess volume. So for hypertrophic cardiomyopathy, I want you to think of increased pressure that causes the heart to grow thicker. So when thinking of hypertrophic, don't just think of hypertrophic obstructive cardiomyopathy called HOCM and muscle disarray. Hypertrophic cardiomyopathy is actually a wider category in which HOCM is a subset of that category. So to just think about the most common cause of hypertrophic cardiomyopathy, it is chronic hypertension, leading to increased afterload, which is the force the heart has to overcome to push blood into systemic circulation, leading to demand for the heart to push stronger. To compensate for this, muscle fibers get added in parallel, which means one next to another, to work together to push with higher force. The heart gets thicker and the ejection fraction is preserved, and usually the same end diastolic volume but increased pressure. PMI is also lateralized, reflecting left ventricular hypertrophy. And the causes are hypertension, aortic stenosis, and hypertrophic obstructive cardiomyopathy, which is asymmetrical left ventricular hypertrophy due to muscle disarray, causing left ventricle outlet obstruction. So the treatment is cessation of high-intensity athletics if HOCM, use of beta blocker or non-dihydropyridine calcium channel blockers, and avoid drugs that decrease the preload further. So the last category of cardiomyopathy is restrictive cardiomyopathy. I want you to think of this as heart muscle fibers not working as intended due to some structural issue. There is usually decreased elasticity of myocardium that leads to less compliance. The heart is usually the same size but cannot pump as well. So this is usually due to infiltrative disease such as amyloidosis, sarcoidosis, hemochromatosis, scarring and fibrosis, scleroderma, and Loeffler syndrome. So in restrictive cardiomyopathy, there is usually presentation of right heart failure due to less threshold for pathologic disease. On EKG, there will be low voltage and diminished QRS amplitudes. Okay, so I'm going to talk about a clinical perspective of atherosclerosis, not really getting into the pathogenesis. I will briefly touch on that, but for family med and IM shelves, make sure you know the USPTSF screening guidelines like the back of your hand. It's like when screening is indicated in which populations, and a large number of questions show up that ask you what is the next step and when you start screening. So if there's A or B recommendation that are really important, C is less. Don't worry about D, but just know why it's not recommended. And so I'm going to get into atherosclerosis. So atherosclerosis is a thickening of the intima due to plaque in medium to large vessels. It's most often due to lipid deposition. So just to review pathogenesis, there's first endothelial dysfunction, where LDL can enter the intima of the arteries and become oxidized. Then monocytes migrate to the intima, become macrophages, take in oxidized LDL, form foam cells, then accumulation of foam cells forms fatty streaks, then smooth muscle cells migrate and produce extracellular collagen matrix, and the lipid core becomes surrounded by fibrous plaque. To screen for atherosclerosis, we typically monitor LDL levels to make sure they're not elevated, and we can also do a coronary calcium score. General recommendations are screening starting at 20 years for both women and men, and LDL should be less than 100. If 100 to 190, you have to measure the ACCVD risk using a calculator, and then recommend changes to lifestyle or statins. If greater than 10% risk in the next 10 years, that is significant and you should start a statin. If resistant to administration of the medication, then you give them 3 months to change their lipids using diet modification and exercise. If greater than 190, you work up for familiar hypercholesterolemia, and if present, treat accordingly. Whether or not the patient has FH, recommend the statin and use high-dose statin like rosuvastatin. So HDL is an important measure. Good HDL is above 40 for men and above 50 for women. The higher the better, and this can be increased with aerobic exercise and supplements like fish oil and niacin. However, clinically significant is when the LDL-HDL ratio is greater than 3 to 1. So triglycerides should be less than 150, total cholesterol should be below 200, but these are just general recommendations. What's more significant is the LDL. So the USPTSF recommends screening for hypertension for adults 18 years or older at every visit. If office blood pressure is greater than 130/80, you measure again with ambulatory blood pressure management, which is a device that you wear throughout the day and that measures your blood pressure, or home blood pressure monitoring, where you record your blood pressure at various times in the day for multiple days. And you measure 3 times over weeks in office and take the average measurement. So the causes of hypertension are either primary or secondary. Primary is called essential hypertension, which can be idiopathic or reasons we don't know, or due to increased vascular tone, decreased compliance of arteries with age, genetics, high salt, obesity, inactivity, alcohol, stress, and smoking. Secondary hypertension is hypertension due to a secondary systemic cause. Could be due to chronic kidney disease, fibromuscular dysplasia, hyperplastic or hyaline arteriosclerosis, diabetes, and other causes. Secondary hypertension requires treatment of the underlying cause. However, regardless of why there is hypertension, you have to treat it. A study published in Lancet by Etihad et al. Stated that just reducing hypertension to reasonable levels reduces all-cause mortality by 13%. If stage 1 hypertension, which is characterized as 130 to 139 systolic and 80 to 89 diastolic, you should recommend one antihypertensive. If stage 2, which is greater than 140 systolic and greater than 90 diastolic hypertension, you should recommend 2 antihypertensive to initiate treatment. If resistant to medication and under threshold of hypertensive urgency, which is 180/120 without signs of end organ damage, give them 3 months to make changes to lifestyle and diet. Recommend the DASH diet, which is high in fruits and vegetables and low in saturated and total fats, and weight loss, aerobic exercise, low sodium, and moderate alcohol use. So hypertensive emergency is blood pressure greater than 180/120 with evidence of end organ damage such as loss of vision, oliguria, which is low urine output, acute mesenteric ischemia, acute abdominal pain with GI bleeding, pulmonary edema, and stroke. You have to immediately lower blood pressure using drugs using hydralazine, sodium nitroprusside, and nicardipine if there is hypertensive emergency. It is important to reduce to reasonable levels as to prevent end organ damage. So I'm going to talk about the drug treatment of hypertension. This is published in the Davidson book for internal medicine. So if less than 55 years with stage 1, treat with ACE inhibitors or ARBs. If greater than 55 years or African or Caribbean descent of any age, I know ethnic bias is outdated, but medical literature needs to catch up. Until then, we follow this algorithm, which is if greater than 55 years or African or Caribbean descent of any age, you treat with calcium channel blockers. Step 2 is if stage 2 hypertension and you need to add either the other. So like if you had the ACE inhibitor or ARB, you add the calcium channel blocker. If you have the calcium channel blocker, you add the ACE inhibitor or ARB. Step 3 is treatment resistant when you add the thiazide diuretic. If resistant to treatment, add spironolactone or alpha or beta blocker and consult to cardiology. So we're going to talk about angina right now. So there are 3 types of angina. I want you to remember that if you draw out the heart muscle tissue from interior to exterior and the artery supplying it, you don't have to do this, but basically it helps you understand. So the first layer to get damaged is the most interior, which is the subendocardium. And when this is damaged, you can get ST segment depression or T-wave inversion. Then the myocardium and epicardium can also get damaged with prolonged ischemia. And this leads to transmural damage, which leads to ST segment elevation. So there are 3 types of angina, stable, unstable, and vasospastic. So stable angina is recurrent chest pain on exertion, emotional or physical stress that is relieved by rest or nitroglycerin. This happens when arteries are greater than 70% blockage. Can lead to ischemic heart disease, There are usually no findings on ECG, but can cause ST segment depression if significant. Unstable angina is pain at rest that happens when a plaque ruptures and causes thrombotic occlusion of artery. Has ST segment depression or T wave inversion. It is relieved by nitroglycerin to open up the artery. Can also progress further to block temporarily or block the entire artery, causing either NSTEMI or STEMI. NSTEMI, I want you to think, is partial occlusion due to ruptured plaque. Troponins will be elevated and ECG will show inverted T waves and ST segment depression. STEMI is complete occlusion of the artery due to ruptured plaque causing transmural ischemia and necrosis leading to ST elevation. Vasospastic or Prinzmetal angina is vasospasm of coronary arteries, and if completely clamps causes the same thing. This is relieved by nitroglycerin or calcium channel blockers. So now we're going to talk about myocardial infarction, or commonly known as heart attack. So angina can progress to MI if ischemia is greater than 20 minutes. This is the most common cause of MI, but myocardial infarction definition is ischemic necrosis of myocardial tissue. Can also be due to other conditions like artery dissection, an embolus blocking artery, chest injury, viral infection, arrhythmia. It is important to differentiate chest pain due to MI versus other causes. So for example, you have to rule out, so if it's a burning pain after eating or during night when sleeping with a sour taste in the mouth, this could be GERD. If sharp pain with movement, think pleuritis from lungs. If pain with palpation of ribs, think costochondritis. The typical presentation of chest pain due to MI is pressure on the chest that feels like an elephant is sitting on it. Can radiate to the arm, jaw, or back. It is important to note that we should not wait on troponins to treat MI. If you think a patient is presenting with MI, have them chew a baby aspirin if they're not allergic, get an EKG to show if there are any ST elevations showing transmural necrosis. Troponin I rises 2 to 4 hours after MI, peaks at 24 hours, and returns to normal in 7 to 10 days. CKMB rises in 4 to 6 hours, peaks at 24, and returns to normal 72 hours or 3 days. Remember, time is muscle. The faster you treat it, the better for long-term recovery. Have the patient chew an aspirin, transfer to PCI capable hospital within 120 minutes. The door to balloon time should be less than 90 minutes, and treat with angioplasty. Otherwise, treat with thrombolytics, alteplase, retaplase, or streptokinase. This could also be treated with CABG or coronary artery bypass graft. So you want to manage with after the operation with supplemental O2, aspirin, antiplatelet therapy, anticoagulation, high-dose statin, and beta blocker unless there's heart failure. Then you don't use a beta blocker. You also don't use a beta blocker if there's bradycardia or severe asthma. So I just want to go over the valvular disorders because there are quite a few questions on murmurs on boards. So the 4 listening posts, all physicians take money, are aortic, pulmonic, tricuspid, and mitral. At aortic area, the high yield to know is aortic stenosis. At pulmonic, the high yield is pulmonary stenosis, atrial septal defect, and flow murmur. Very close to the pulmonic area is the left sternal border, where you can hear hypertrophic cardiomyopathy and aortic and pulmonic regurgitation. In the tricuspid, you can hear tricuspid regurgitation and ventral septal defect. And then mitral, you can hear mitral regurgitation, mitral valve prolapse, and mitral stenosis. And lateral to the mitral valve, you have the PMI, where you can hear S3 and S4. So just to characterize these murmurs and explain them a little bit further, what helps is knowing what the maneuvers do and understanding what preload and afterload is. So, as I stated before, preload is end diastolic volume. It's basically how much blood is in the heart at the end of diastole. And afterload is force the heart has to overcome to push blood out. Once you understand that, then you need to think, oh, is this murmur an obstruction or regurgitation? If obstruction, it becomes more pronounced when there is more fluid in the heart, and less pronounced if there is increased afterload, because there's less blood flowing forward. If regurgitation, it becomes more pronounced when there's increased afterload, as there's more force pushing blood back through the valves, and becomes more pronounced if there's more fluid in the heart or increased preload for more regurgitation to happen. Another rule of thumb is that if there's an I in right, so right side murmurs increase with inspiration, and the E in left, so left side murmurs increase with expiration. Just think about what maneuvers do to preload and afterload. So standing decreases preload, passive leg raise increases preload, squatting increases preload and increases afterload, hand grip increases afterload, inspiration increases preload to right heart, and decreased preload to left heart. So the two exceptions to this reasoning is mitral valve prolapse and hokum. So just know they're not ordinary murmurs. They don't obey the preload dynamics, because the less fluid in the heart, the more you can hear them. So just to go over the murmurs themselves, aortic stenosis is a systolic crescendo decrescendo ejection murmur. Mitral tricuspid regurgitation, mitral and tricuspid regurgitation is a holosystolic, high-pitched blowing murmur. Mitral valve prolapse is a late systolic crescendo murmur with a mid-systolic click. Ventricular septal defect is a holosystolic, harsh-sounding murmur. Aortic regurgitation is an early diastolic decrescendo murmur. Mitral stenosis is a late decrescendo murmur with an opening snap. PDA is a continuous, machine-like murmur heard in the left infraclavicular area, loudest at S2. S3 is heard after S2, and S4 is heard before S1. I'd recommend the flashcard deck Anking. You can find it online. That's spelled Anking. They have cards with the murmurs on them. You can play the sounds and quiz yourself. So that concludes this presentation.